Abnormal uterine bleeding. Any uterine bleeding outside the normal volume, normal duration, normal regularity and normal frequency is called as abnormal uterine bleeding. So what is normal? Volume is 20 to 80 ml, average being 35, duration is day 1 to day 5, normal menstrual cycle. Etiology, it is given by FIGO 2011 classification, which is a palm coin classification. P for polyp, A for adenomyosis, L for leiomyoma, M for malignancy, C for coagulopathy, O for ovulatory dysfunction, I for heterogenic and N for not yet identified. So what are the various patterns of the abnormal uterine bleeding? First being menorrhagia, increased volume and duration. Second is polyrhagia, increased frequency of menstruation. Third being metrorrhagia, which is a regulatory disturbance. Third and fourth is menometrorrhagia, which is a volume as well as regulatory disturbances. So what is DUB? DUB is a dysfunctional uterine bleeding, a state of abnormal uterine bleeding without any clinically detectable organic, systemic or heterogenic causes. So why and how it is occurring? So what is the pathogenesis behind this? Normal mechanism of hemostasis is as follows. It is platelet adhesion and formation of platelet plug, localized vasoconstriction and regeneration of endometrium. So normally what occurs? There is a secretion of PGF2 alpha which causes vasoconstriction and reduce bleeding. And this PGF2 alpha is also increased by a hormone, that is progesterone, which indirectly reduces bleeding. Second factor is endothelium, which is powerful vasoconstrictor. In abnormal uterine bleeding, what occurs? PGF2 alpha is decreased, endotheliums are decreased and PGE2 is increased, which causes bleeding. AUB may be associated with ovulatory bleeding or anovulatory bleeding. Ovulatory bleeding is further polymenorrhagic or oligomenorrhagic, and anovulatory is menorrhagic as well or cystic glandular hyperplasia. So what is polymenorrhagic? There is a speeded follicular growth due to overstimulation of FSH, and oligomenorrhagia, understimulation or unresponsiveness of FSH. Menorrhagia is no progesterone, only estrogen is active and active on endometrium, which causes throughout the cycle growth of endometrial and hyperplasia. On negative feedback of FSH on estrogen, the bleeding occurs. Cystic glandular hyperplasia is a mostly premenopausal condition and it is same as the menorrhagia. So what is the investigation? First, history. Bleeding from vagina is confirmed on history. IUCD or contraception insertion is also asked in history. Volume of blood loss is estimated. So general examination, pallor, icterus, edema, thyroid state is checked. Blood culture, CBC, ESR, HB, DLC and TLC is checked. Special investigations being transvaginal sonography, endometrial thickness is measured. Normally it is 4 to 12, atrophy less than 4 mm, hyperplasia more than 12 mm. Color Doppler is also, and MRI, USG, hysteroscopy, saline infusion sonography is used. Management. What is the management? First step is general management, rest, nutrition, anemia, control. Second being medical management, non-hormonal and hormonal management. Non-hormonal, non-steroidal anti-inflammatory and antifibrinolytic. Ibuprofen, nimesulide are NSAIDs and tranexamic acid is antifibrinolytic. What is hormonal? Then hormonal progestins are orally active anti-estrogenic activity drugs which are negatively block the 17-hydroxysteroid hormone. They also block the receptors for estrogen on endometrium. Example being norethestone acetate, medroxyprogesterone acetate. What is the pattern of giving the drugs? Cyclical or continuous. Cyclical being 5th to 25th day and continuous 10 mg medroxyprogesterone acetate for 90 days. Surgical management, uterine curette is done, endometrial ablation and recession is done. Third being uterine thermal balloon destruction of the endometrium is done, and fourth being transcervical resection of endometrial, and last is hysterectomy, and age 40.